this live activity for a maximum of 1 AMA PRA Category 1 credits. And we will be mailing forms to obtain credit to all attendees in the next day or two. We are so pleased to start this first webinar with 3 national cardiac rehabilitation experts, and they are leading today's presentation on the benefits of increasing cardiac rehabilitation. They bring a wealth of experience and knowledge to this topic. Dr. Randy Thomas is the Medical Director for the Mayo Clinic Cardiac Rehabilitation Program. He's currently Chair of the American Heart Association's Council on Clinical Cardiology, and he has published widely on cardiac rehabilitation research and policy. Karen Louie is a nurse and exercise physiologist who directed hospital-based cardiac rehabilitation programs for 25 years. She's now at AHRQ and serves as a legislative and regulatory analyst for the American Association of Cardiovascular and Pulmonary Rehabilitation, and that involves working very closely with the Centers for Medicare and Medicaid and with Congress. Greg Merritt is the founder of Patient is Partner. He has spent the past 3 years studying, speaking, and writing on the topic of authentic patient partnerships, both in research and practice, and he is also a cardiac rehabilitation graduate. Greg is going to start us off with a personal story about the benefits of cardiac rehabilitation and why all of this matters.
Thanks, everybody. Sorry, I just want to point out I am a incredibly grateful patient living a very gifted second life, and I care deeply about this stuff and the power and possibility of cardiac rehab. And I just want to tell you my story about how, if we can continue to partner with our patients, I think we might have ways to really affect the usage of cardiac rehab in the future. So my story begins on February 25th, 2012. And I woke up and said to my lovely bride, I think I've got heartburn. And she said to me, yeah, you don't have heartburn, you don't get it, and you haven't anything to eat. We should go to the hospital. I, of course, like far too many of us patients in the world, poo-pooed the idea, took some Tums, but something ultimately got me to go. And though I wouldn't recommend this for others, we took off in her car, headed down about 20 miles to the University of Michigan. We get about 6.2 miles from the hospital. I apparently grasped at my chest and clutched, and I had a sudden cardiac arrest and a heart attack. She then had to make some tough decisions, including whether to keep going. She kept going. I turned blue-lipped and ashy. Arrive at the hospital. They pull me out. They do 20 minutes of work on me. Ultimately, the attending comes and asks if she'd like to continue. Lucky for me, she said yes, although she may be thinking about that over the last 7 years. And ultimately rushed in, finally get a rhythm back about 6 minutes after that, rushed to the cath lab, 2 stents, and then 5 days in cardiac ICU using medical hypothermia, which saved much of the functions that I had, both, well, you could make a decision about my brain, but other ways in which this was positive. The thing that matters so much to me about cardiac rehab is I was given an automatic referral to go to cardiac rehab. I think that made all the difference for me. I happen to be one of those patients, and I suspect most of us are. If when you're discharged, there's a set of things that you're supposed to do, including follow-up. That follow-up took place. That mattered a lot for me in terms of, why I showed up, and ultimately now why I believe that it's so important to engage many more patients in persuading healthcare centers and hospital systems about the powers and benefits of having a quality of life, having gone through cardiac rehab, having graduated, and now working on ways to have many patients become advocates and partners in the process of assuring cardiac rehab is increasing its usage. So that's why, for me, why all this matters, and I'm hopeful as you hear my colleagues today, you'll see the benefits and power as to why it matters to me and why it will matter to so many other patients like me.
Thank you, Greg. I'm going to now just talk a little bit about what is TAKEheart. and talk a little bit about some background to this whole initiative. TAKEheart is an agency for healthcare research and quality initiative. It's designed to enable hospitals and health systems to increase cardiac rehabilitation referrals, enrollment, and participation, and it's based on evidence. So the webinar presents strategies and specific interventions that partner hospitals will be undertaking in TAKEheart and evidence for why they're effective. And many of the strategies you're going to hear about today come from the CDC Million Hearts Cardiac Rehabilitation Change Package. So TAKEheart offers partner hospitals a virtual training curriculum on how to increase cardiac rehabilitation among eligible patients using evidence-based quality improvement strategies focused on automatic patient referral and care coordination. And I think I just am going to touch on some definitions here. Automatic referral is a medical record-based referral where an order for cardiac rehabilitation is generated for patients who have designated diagnosis and for which outpatient cardiac rehabilitation is recommended. So this order is generated as a default action, and providers need to actively opt out not to have the referral move forward. So this referral, with the appropriate communication to patients and follow-up by clinical professionals, is designed to result in an efficient, systematic referral to outpatient cardiac rehabilitation during the hospital discharge process. And then care coordination support means someone who manages a patient's care from their inpatient visit through their referral to cardiac rehabilitation and on to their engagement in the rehabilitation itself. The care coordinator educates the patient about the benefits of cardiac rehabilitation and works with the patient to reduce any barriers to participation, including creating or strengthening linkages to outpatient cardiac rehabilitation. And the purpose of these two interventions is to increase the use of cardiac rehabilitation. So this is the first in a series of 10 training modules, and over the course of these 10 modules, we're going to walk through the steps and considerations of how to implement automatic referral to cardiac rehabilitation with care coordination. And today is focused on evidence and making the case for cardiac rehabilitation implementation. So we're going to talk about the learning goals. What is cardiac rehabilitation, the importance and opportunity to close the gap, barriers to patient participation, evidence, and then we'll open it up for discussion at the end. Upon completion of the module, you should be able to understand the evidence base for increasing cardiac rehabilitation through the means that we've talked about, making the case to your leadership for taking active steps to increase cardiac rehabilitation participation and by participating in this project, and to feel confident that the TAKEheart curriculum will provide you with practical tips and tools to implement automatic referral with care coordination. And now I'm going to turn it over to Randy.
All right, well, thank you, and it's good to be part of this webinar. I hope that this is a meaningful experience for you, and hope that the information that we're providing will be beneficial to you. The task I've been given is to walk through a few of the reasons and explanations of cardiac rehabilitation, and then we'll have some time for some questions at the end as well. I think the story that Greg told is very powerful. And I think if we all think for a moment about what experience he's been through, it's pretty remarkable. We're so grateful that we have emergency response professionals and coronary angiography specialists and interventionalists, and we have people all along the way to help save the lives of individuals going through the cardiac event. And yet, as we look at what happens after hospitalization, sometimes we drop the ball. In fact, unfortunately, often we drop the ball and don't help the survivors of cardiac events to receive all the benefits of ongoing care that they need. Cardiac rehabilitation is a systematic approach to providing secondary prevention therapies to individuals who've had a cardiac event. The typical program includes 36 one-hour sessions, usually 3 sessions per week for about 12 weeks, although it can be varied according to the patient needs. It's a multidisciplinary approach to applying the therapies we know help people avoid subsequent cardiovascular events and live longer and have a better quality of life, supervise exercise, patient counseling, nutrition, and lifestyle education, making sure patients are receiving the medical and lifestyle therapies they need, and also addressing comorbid conditions that they might have that are important as well. Next slide. Can we get the next slide, please? There we go. The importance of cardiac rehabilitation is very clear, and Karen Louie will talk about some of the benefits and evidence behind cardiac rehabilitation more in just a moment. But unfortunately, as we look at this evidence more and more, and there's been evidence that's been accumulating over the past decades to show the benefits of cardiac rehabilitation, and no matter what outcome you look at, you will find improvements as patients participate in cardiac rehabilitation, whether it's living longer, better quality of life, lower readmission rates, higher adherence to preventive therapies. There's a number of important benefits. But unfortunately, there's a large gap between enrolling, being eligible for rehabilitation and enrolling in rehabilitation. According to a 2019 study, for example, among Medicare beneficiaries, 24.4% of those who were eligible for cardiac rehabilitation actually participated, and of those, only 24% made it to cardiac rehabilitation within 21 days, and of those who went to cardiac rehabilitation, only about 27% participated in all sessions. And we'll talk about this more, but the sooner a patient gets in and the more sessions they attend, the better the outcomes. So this shows us that only a small percentage of eligible patients are receiving the life-saving therapy that cardiac rehabilitation provides. The TAKEheart initiative is to help close the gap between what we know we should be doing and what we're actually doing. So a few years ago, as part of the Million Hearts Cardiac Rehabilitation Collaborative, several of us got together and we asked the question, what would happen if we had a wildly successful program that could increase participation rates in cardiac rehabilitation from around 20% to around 70%. Still not 100%, but much better than the 20%. And what we found as we looked through the data was we estimated around 25,000 lives would be saved per year and 180,000 hospitalizations saved per year if we could make such an improvement. So it's already been mentioned that there are a few evidence-based strategies that can help us make this happen. One is the automatic referral, and this can be done either in a paper-based version or electronic medical record version, where a patient who is eligible, and this would be those who have MI, myocardial infarction, angioplasty, PCI, coronary bypass surgery, heart valve surgery, transplant surgery, heart failure with reduced ejection fraction, or stable angina. If they are identified, automatically referred, that by itself is a big step toward getting patients into rehabilitation. In fact, the referral process is the key in getting people into cardiac rehabilitation. The second step to help with that, as was mentioned, is a navigator, a liaison, or a care coordinator in the hospital setting who can help those patients who've been identified who should be referred to rehabilitation to navigate their way to the rehabilitation program. And this also is a fairly simple step, but one that has significant impact. In fact, in a 2011 study from Canada, by implementing these strategies of automatic referral, first of all, they found that the participation rate in cardiac rehabilitation in the control hospitals, 32%, went up to 70% in those hospitals who use the automatic referral system. And those hospitals that also had the care coordinator or navigator, in addition to the automatic referral, participation rates went to 86%. So just those two simple, relatively simple steps had that big of an impact. Well, you might stop and ask yourselves, why the problem getting people into cardiac rehabilitation? If it's so helpful, why isn't this happening more often? Well, it's a multi-level problem and multiple barriers that prevent participation. At the provider level, many providers fail to promptly and consistently identify and refer patients who are eligible for cardiac rehabilitation. They have a focus on inpatient care that sometimes distracts them from other things that they may need to be thinking about in the outpatient setting. And there are some who do not understand the importance, benefits, and the operations of cardiac rehabilitation. They may assume that others are going to take care of it, or some feel like it may not be that helpful in the patients they're taking care of. For the patients, they have a number of barriers as well. Of course, if they're not getting referred to cardiac rehabilitation or they have a lack of care coordination, they may not know how to maneuver their way to cardiac rehabilitation. They may also have a lack of understanding about the importance, scope, and benefits of cardiac rehabilitation, not realizing that it would be beneficial for them. And they also have significant barriers, including time barriers, time at home or at work that may make it difficult for them to go into a program. They may lack motivation, may lack support around them. There may be financial restraints, including co-payments, and they may lack transportation that would help them to get to these 36 separate sessions of cardiac rehabilitation. Also, there are significant disparities for patients, and in particular, women, people of color, non-native English speakers, and actually the elderly as well, all participate at much lower rates than their counterparts. In one study, 18.9% of women participated in cardiac rehabilitation compared to 28.6% of men, and non-Hispanic whites participated at a rate of 25.8% compared to less than 17% for those from other races and ethnic groups. In areas of the country where cardiac events are disproportionately high, including the southeastern United States, cardiac rehabilitation is among the lowest in the country. Individuals also with multiple comorbid conditions are less likely to be referred to and participate in cardiac rehabilitation because of the perceived barriers that their comorbid conditions represent. And then hospital and healthcare systems also have a series of barriers that they face. Outpatient cardiac rehabilitation is challenging to coordinate and to sustain from an inpatient referral system, particularly without an automatic referral system that helps to identify patients more easily. There's generally a lack of coordinated operational and IT platforms and staff that are serving in both the inpatient and outpatient setting that can make it more seamless for getting patients from one site to the other. And finally, there's a need for hospital leadership support, where cardiac rehabilitation often is not traditionally seen as acutely important for a variety of reasons. So I'm going to turn the time over to Karen, who's going to take it from here.
Thank you, Randy. And Greg, thank you for taking us back to the reason why we're all here today. Cardiac rehab's a well-kept secret, and what we're finding, researching, and trying to promote is quite worth all the time and effort. I'd like to spend a little time on making the case for patients. You know, we could talk statistics all day. We know that cardiac rehab reduces mortality by up to 24%. That's pretty dramatic. That's probably equivalent to the best drugs and interventions that we have today to treat heart disease. An impressive statistic. It reduces avoidable, and keep that key word in mind, avoidable rehospitalization, even up to 30%. And that's powerful data. If we can help patients make an informed decision to come to cardiac rehab, then we've done our job. And I'm sure the hospitalization is fresh in minds when they're being referred to cardiac rehab, and I'm sure at that point they'd be willing to do anything to avoid having to go back to that place. So we can, very confidently say that there are steps they can take to make a difference. Randy went through the bulleted diagnoses here that are folks who are eligible to go to cardiac rehab. This is the Medicare criteria. Most private insurance covers these same diagnoses. Sometimes private covers even other heart conditions. When you look to the left side of this and you see more statistics, that if somebody attends 36 sessions, that is, completes a cardiac rehab course, they have a dramatic lower risk of death and heart attack than those who come, say, for only one session. So it's a fair question to say, well, how much is enough? And we know from the data here from Hamill et al., and that reference is in your slide resources, that bottom line is more is better. The benefit is dose dependent for all these diagnoses, and that's unrelated to the degree of disease that a person has, the number of risk factors, or age. So it's a blanket statement that's true for all, and that's pretty powerful stuff. Next slide, please. The care coordination that Randy defined is really central to this. A liaison referral, another term that we use to call it, can be provided in a variety of ways. It's just the personal touch. It's the people part of it. It's the connection made. And an inpatient connection is quite powerful. Earlier in the slides, it was referenced the CDC Cardiac Rehab Change Package. In that document, there are 3 centers listed who are successful at doing this, and they're all different strategies. Mass General has a self-referral strategy for those who, for whatever reason, kind of missed being referred, kind of fell through the cracks. An outpatient liaison is another way to do it. If someone can be in the hospital and say, look, I'm the face you're going to see when you are discharged and come to cardiac rehab, it goes a long way. One of my cardiologists, what I call my cardiac rehab champion, he would call me from the patient bedside on the day he was going by to discharge and say, Karen, I want you to call Mr. So-and-so tomorrow and sign him up for cardiac rehab. You know, the expectation was pretty clear to that patient and the significant other in that room that they were expected to come to cardiac rehab, and that went a long way. This is active care coordination. And why was my cardiologist so insistent on cardiac rehab? For all the reasons on this page. You know, the cardiac rehab staff are behavior change specialists. Randy mentioned secondary prevention, and that's the list of lifestyle choices here in the second bullet. And these are secondary prevention and things that we can help patients with. But what's real important is what matters most to the patient. You know, they may not relate to a 24% decrease in mortality rate, but they may want to make it to see their next grandchild be born. Our role is to help the patient and the family find what the motivating factor is that drives that person to agree to participate in cardiac rehab. And then we can do the rest. That liaison care coordinator helps find that patient, find the reason why they would want to participate. So cardiac rehab then focuses on each patient's behavior change goals. So cardiac rehab is patient-centric, really. It meets the patient where he or she is at in their long list, perhaps, of lifestyle changes where they don't know where to start, or there's some they're willing to start and others not yet. Next slide, please. Quality benchmarks are increasingly important to hospitals. The national guidelines indicate that cardiac rehab is a Class A1 recommendation for heart attack and bypass. That's standard of care in the treatment of heart disease. So cardiac rehab promotes better quality care management, and it, as an earlier intervention, reduces those avoidable, again that word, avoidable adverse events. Cardiac rehab reduces emergency visit, avoidable hospitalizations, unnecessary physician office visits. We see that all the time in cardiac rehab, and less long-term care utilization. We know this from our studies. So it's a relatively low-cost intervention compared to some of the inpatient interventions and treatments that are fortunately here for acute cardiac conditions. But cardiac rehab provides a high return on investment given the impact of its benefits. The bottom line is improved outcomes that hospitals and payers are increasingly caring about. This provides a financial advantage to participation in cardiac rehab. Next slide. Very briefly, just a reimbursement overview. Cardiac rehab is an outpatient service, so it's under Medicare Part B. And most, I would say all, I've not come across one in a long, long time where it wasn't part of coverage for someone who is insured. Cardiac rehab is always in there. And the reimbursement for cardiac rehab has kept up over the last, since the 80s when we've had reimbursement for it. There are 2 codes for cardiac rehab, and they've been around since the 80s. It's considered a comprehensive service, so these are the comprehensive codes, and they're equally important and required for both education, counseling, as we've talked about, and exercise. As we mentioned earlier, that cardiac rehab change package is that action guide of strategies to use these codes both cost efficiently and effectively. That cardiac rehab change package has best practice examples of what is working successfully for a number of programs to achieve these 2 goals. In that package are links to these programs so that you can actually communicate with them and say, what did you do? Why did it work for you? So your plan can be guided by others who've gone before you and been, are actually successful in doing it a better way. Next slide. We all know how important tracking data is, and that's part of the TAKEheart project to support quality improvement. Measuring data improves outcomes. We all know this, and just like tracking referrals, increases referrals. Cardiac metrics like referral rates, enrollment rates, adherence rates, and time to get into the program are also being incorporated into quality performance programs and can really help drive reimbursement. This need for data calls for program self-analysis on these metrics, easily obtainable, as Randy said. I think not hard, not a barrier to do. Remember, go back to what we know, more is better for the patients. So reporting performance and quality metrics promotes a health system's ability to work in a value-based, and I know that's a familiar term now more and more, risk-taking environment, particularly among payers. This shift to value-based performance, or value-based care is the current term, is happening. And we now have quality measures we live with from CMS, from Medicare, as in HEDIS. We have registries that track. We have accountable care organizations. And these are getting more robust and certainly not going away. Let me give you one example and drill down. The next slide, please. Even CMS has gotten in on the act about 7 years ago now. Payers recognize the importance of managing cardiac care and are increasingly highlighting the importance of cardiac rehab. CMS has an innovation center. They've had a project called Bundle Payments for Care Improvement, BPCI. This is one example of a value-based program that incentivizes better outcomes and reduces unnecessary expenditures. There are about 31 diagnoses included in the current BPCI bundles. These are 90-day episodes where one payment is made at the end of that hospitalization and 90 days after. So while improving cardiac care overall is incentivized, for that reason, cardiac rehab is not counted as part of the BPCI payment calculation. What that means is the hospitals get the benefit of better outcomes when they more often refer to cardiac rehab, and the cost of cardiac rehab is not part of that bundle payment. This is pretty huge. It means that CMS recognizes that cardiac rehab utilization incentivizes good outcomes. So CMS's goal, as ours is to encourage, not discourage, use of cardiac rehab, knowing that downstream cost savings are there for patients who do receive cardiac rehab. With that, let me pass the next slide back to Greg.
Thanks, Randy and Karen. I suspect all of you are like me, that if you just listen to Randy and Karen, you are now totally persuaded about this. And if not, I'll do some summation from, again, a patient perspective to let you know and how you might want to think about this in persuading your leadership to assure that you're increasing the usage of cardiac rehab. In some, we've got it reduces mortality, readmissions. I can assure you that somebody who's had a heart attack, I'm sort of for that. That's a good thing. And most importantly for me is it increases the quality of life and outcomes as well. So I end up being in a place that I know I can still and want to walk the dogs and be with my nieces and nephews and see what happens as they have children and those kinds of things. So all of that matters. As we know, again, from hearing from Karen as well, these improved outcomes help everybody. So the hospital and health systems obviously benefit. Less people actually having secondary events after the initial event is important. And maybe most importantly, from a just sheer cost perspective, it is a more cost-effective model. It can and hopefully will be continually rewarded by payers as we move into value-based payment contracts in a way in which we assure that the best outcomes are with those who don't end up having new episodes, who don't end up finding themselves back in the hospital, and whose lives are much improved by the work of cardiac rehab. I know that I speak not just for myself, but everybody else who's actually been in cardiac rehab and graduated, and those who will come. We all want to just have one graduation. I'm not looking for two graduations. And that being said, the still hope is that that more usage of cardiac rehab, the better this will be for all of us who are grateful for all the work that you all do.
Okay, great. Thank you, Greg. Thank you, Karen. Thank you, Randy. So as next steps, we would encourage everybody to make the case to your team and to your leadership about why cardiac rehabilitation is worth investing in and using the evidence here. On the TAKEheart website, you will find resources and you'll find the slides, which we will also mail out. You'll find an implementation guide and a fact sheet with resources. So we would just encourage you to access those resources and think about how you can make the case in your own hospital. So in future webinars, again, our role is to support you in coming up with automatic referral and care coordination in your hospitals. So we're going to discuss, change management, how to develop an action plan, modifying workflows, developing the role of the care coordinator or the patient navigator, how to engage all patients, ensuring access, and more. And we really look forward to working with you. And I can say that on behalf of all of our experts and all of our national training team. And now I think we would like to open it up to questions. On this slide, you can see that the way to ask questions is to open the chat box, which you do by clicking on the little talk bubble at the bottom of your screen, and select all panelists in the to box and just put in a question. And maybe to start things off, I know that Karen and Randy and Greg, you all have been involved in thinking about how to increase cardiac rehabilitation participation. You've been involved in the Million Hearts Cardiac Rehabilitation Collaborative. And I'm just interested if there is any advice that you'd like to give to the partner hospitals as they enter into this process of implementing automatic referral with care coordination. And maybe, Karen, do you want to start?
Been pulling, thanks. Million Hearts has been pulling together many different entities, payers, government entities, hospitals, providers, patients, and it's been a very interesting journey since 2016 when many interested parties came together. And I think it's really brought it to the forefront where there's more talk about it, there's more familiarity with it. I think hospital administrations are a challenging group to get to because they're, of course, over many things and attention is widespread. So I think that, along with the challenge of payers, educating payers to recognize and design reimbursement paradigms to encourage the way the CMS BPCI bundle has, will go a long way. The co-pays, as Randy pointed out, is a barrier, definitely a barrier that we continually try and resolve. On the other hand, the co-pays in the Medicare program are not so exorbitant that what you get from that for the part that you're financially responsible for almost makes it, the value is there. And people, I think, understand that after they've started the cardiac rehab and are going along, and they recognize that the value is worth the copay that they're facing. Let Randy maybe address the automated referral.
Yeah, I think a couple of things come to my mind. First of all, using local data is very important. Often, if we approach an administrator or a clinician and say that, we talked about this issue, they may have an impression that, we're doing great. We don't have a problem with this. But if you look at local data, that's very powerful. And if you look at local data, you will often and usually find that there are gaps. Even in the centers that are operating up around the 70% participation rate, there are opportunities to improve. So local data, I think, is really key. And then another would be to make sure you look for and secure and nurture key partnerships. And those partnerships might be someone in the quality office of your hospital, the performance measurement group. It might be the cardiovascular surgeons. It might be a patient advocacy group. But I would look for those key partnerships that will help you in your efforts, because they will be a big boost to you as you go about trying to convince and bring others on board too.
Great, thank you. We're getting some questions coming in, and I just want to remind everybody that to write a question in the chat feature, you might need to click the button on the upper right-hand side to show the screen icons. So anyway, if you get full screen, minimize screen, play around with it, and then you'll see a little quote circle, and click on that, and you can put a question into the chat box.
Great. And I wanted to follow up. I'll direct this question to Karen. Could you say a little bit more about the cardiac rehab change package in terms of what it is and how it was developed?
Oh, sure. Yeah, that came out of, actually it came out of, in 2016, CMS was going to incentivize in one of their bundle programs, the BPCI I mentioned earlier. They were going to pay programs for cardiac rehab an extra amount. So they were incentivizing use. And so AACVPR got pretty excited about that and said, whoa, now we have a capacity problem, don't we? Because we've been rolling along with 20% of patients using it. And if there's financial incentive from Medicare to use it more, we have to ramp up. How can we do it better? How can we be more efficient? So AACVPR started down that line of gathering best practice examples, efficiency, better delivery, better services, 5 days a week, not just 3, open gym, not just slotted classes, don't have to monitor everybody, many, many strategies. And at that point, Million Hearts stepped in and helped immensely. And CDC has the brain power that's just the best, and came in, and together we put together this cardiac rehab change package that's really an online, so that it's a URL where you click on the link and it will take you to the program and what their strategy is that they're using. You can contact different people, a very interactive tool that's available, posted on the Million Hearts website, on the AACVPR website. And you can start where you need to. And so as Randy said, we need our local data, and you analyze your own program. If the referral is the huge gap, you might start with the strategy in the referral section. If that's not the problem, but the getting patients in because of capacity limitations is the problem, you'd go to that section and look at those strategies and say, well, what are we best capable of doing right now? What can we put into action? What do we want to? So a really usable, tangible tool for program improvement based on what you see, where your largest gaps are.
Thank you, Karen. And I just want to remind everybody, or let you know, that the cardiac rehabilitation change package, as well as these slides, are part of what our training team is going to be sending to all participants as a follow-up to this webinar. So you'll receive those. And a reminder that the slides have links embedded in them and have resources. So things that we referenced in the slide deck, you'll be able to go through and link to many of the things we've talked about. And so now I just want to go to more questions that we are receiving. So one, and I'll ask Randy if he wants to take a first stab at this one. How do you suggest that small rural hospitals obtain referrals from tertiary facilities?
Yeah, that's a tough one. I'd say it gets back to partnerships. We have that situation here at our hospital as well. And so over the years, we have developed relationships with the local rural hospitals and vice versa, so that we have a communication system in place to be able to contact the hospitals as patients are being referred to their rehabilitation program. And I think it just takes, again, the setting up those key partnerships, contacting the cardiac rehabilitation professionals at the tertiary hospital, and make sure that that communication line is wide open. I think it's helpful also to give feedback back and forth, and that's something we're trying to do more and more of as well. So as the rural hospitals report back to the tertiary hospital how many patients are actually getting referred over and how many are actually making it in. That's a really helpful communication to have because both hospitals are really jointly responsible for making sure patient is not only referred but also that they enroll in the program. So the key thing is communication lines.
Thank you, Randy. I'm going to move on to the next question. Is there evidence that states what the time frame is in which a person should start CR after an event? Randy, do you want to take that one as well?
Yeah, any time is better than no time, but the sooner they get in, the better. And particularly if you're looking at things like recovery and decreasing readmission rates, the data shows the sooner they get in, the better. And generally, a good rule of thumb would be if you can get them in the week or 2 weeks after hospital discharge, that would be ideal. And that's even for the post-surgical patients. So we get them in right away so we can help them in their recovery. So sooner the better. Generally, most insurance policies, I believe, will still cover cardiac rehabilitation up to a year after their event, although that varies somewhat. But generally, if you want to have the most impact, you're going to want to get them early after their event.
Great. Okay, this question, Karen, I'm going to address to you. In our area, our largest payer only covers intensive cardiac rehab. We have both, let me start this again. In our area, our largest payer only covers intensive cardiac rehab, i.e. Orange program. I don't know what that is, but perhaps you do. And this person says, we have both programs. Do you see this trend in other areas?
I don't understand the issue that they only cover intensive cardiac rehab because Medicare covers cardiac rehab, must cover, or cover intensive cardiac rehab. Now, there are three, I'm going to use the word franchises, there are three separate ICR programs that have been accepted by CMS, and they cover those three programs. So I'm not sure that that's what the question is really asking because clearly insurance covers the traditional cardiac rehab, not just an intensive cardiac rehab. And if they're asking why this intensive cardiac rehab and not another, that's up to that private payer. So, and if it's a private payer, I'd be stunned to find one that does not cover traditional cardiac rehab, but does cover intensive cardiac rehab. And I would love to talk to that person about that scenario.
And sorry, this is Randy Thomas. Sorry, can I jump in just for a second? I agree with what Karen said, and I think it's an opportunity maybe to go and talk to the medical director for that insurance company and explain the wide, the large amount of data supporting cardiac rehabilitation, and as far as participation and a number of reasons. There's some challenges with intensive cardiac rehabilitation. And my read on what's going on around the country is that what you're describing is not a trend that's going to be repeated around the country. It's going to be probably the opposite direction, is my guess. We're trying to find simpler and more accessible ways for people to get into cardiac rehabilitation, and that's kind of in the opposite direction of intensive cardiac rehabilitation generally.
Yeah, I'd agree, Randy.
Okay, thank you. I'm seeing one question that's specifically about working with Epic, and I think one of our panelists is welcome to weigh in, but I will just say that we're going to have an upcoming training session specifically about working with your electronic medical record and working on automatic referral. But having made that plug, the question again is, do we have experience specifically working with Epic to be able to implement the automatic referral? And I don't know if anyone wants to chime in on working with Epic in particular.
I can just say briefly, yes. A number of centers with Epic, including ours, have been working on that. And unfortunately, it's a little bit like reinventing the wheel at each spot. We're working with Epic, hopefully, to help them produce something that'll be a little bit more system-wide, but it is doable. But it's, as far as we can tell, unfortunately, centers are doing it around the country with them individually.
Great. And Karen, here's one for you. One of our barriers is gaining support for the liaison navigator role from senior leadership, even with the points you have made today. Any additional suggestions you can provide to convince that team? Our CR team is busy and not able to consistently get the consult list to complete. So while we have the availability, we don't always have the resources to successfully complete this each day.
Oh, how frustrating that is. And each institution has its challenges on who has the greatest ability to help that patient make the transition. Certainly discharge planners in the hospital, that's a large part of their role, and it could fall to that person. I think it most passionately comes from your outpatient cardiac rehab program, and it's so valuable when you can walk in and say, I'm the one that does it, and I'm the one you're going to see, and here's what's going to happen. But some are doing it with videos before the patient leaves because they just don't have the physical resources to get to everyone. But there's nothing like that in-person navigator, and I would hope that an in-hospital discharge planner, because that's so important more and more in hospitals, would be able to partner with that outpatient department to provide something along those lines. Yeah. The only other thought is that some of the patient groups, they can't do the liaison, but I know there are some places where Mended Hearts come in and say, hi, I'm stopping by. This is a real valuable service if you want to consider it. Those kinds of things. Greg might want to have some thoughts on that.
Yeah, I thought exactly that, Karen, that I think although the formal role, and although this is the question I guess I would raise to the health system, is finding a patient who actually is frustrated about the fact that they learned about this, maybe going to see that healthcare leader to talk about it from a real lived experience. I think the more you can use stories, data matters a lot, but so do stories. And if all it would take actually is, as we now are learning in the news, if somebody really important has an effect on something that doesn't work particularly well, things tend to change. So I would say that to the degree you can find patients who can share the fact that this wasn't just a frustration for you, but actually for them, once they learned that they should have been told about this and weren't.
And the cardiology group, if you could have some champions on your medical staff to also point out the barrier that is. There's your maybe more influential group, within the hospital politics.
Great. And I'll just say we're getting a few questions asking about sort of data requirements and things that will need to be sent as part of TAKEheart, and I just want to let you know that we have information about that and resources, and that will be sent to everyone. So just as a follow-up to that question, we'll be following up on that specifically outside this webinar. Okay, another question. I'll address this, I guess, either to Greg or Karen. Any plans to help, or ideas to help patients, low-income patients, to pay their copay and help arrange transportation?
There are some strategies in the cardiac rehab change package that do have some great ideas to suggest some solutions for that. Some hospitals use foundation money, some very creative ways to help patients. And transportation now, even Medicare is some of the Medicare Advantage plans are allowing some transportation flexibility. So that's actually improving in maybe options that are allowed, that are legal. Greg?
Yeah, I think that's right, and I think so. I think a lot about philanthropy. I think it does matter in who gets asked to give in health systems. And one of the things as a cardiac rehab grad advocate, I wonder why all of your rehabs aren't named from somebody who actually matters. And even if it's not yours, but you learn that they didn't go to your particular hospital, but they're going to go to a low-income area and provide health where obviously the data shows that there aren't enough folks utilizing rehab. And then transportation, again, another place is to think about things like ride-share programs, Uber Health, Lyft, these programs that start to get into the health field may be an important question in your particular area.
Mm-hmm.
Excellent. We had another comment just underscoring the importance that this person feels of getting the buy-in of the physician. I think this was just a comment and not a question, but just to underscore that and just, to ask the participants, maybe I'll go back to Randy just to say anything else that, as a physician, you would just underscore in terms of our participants today making the case to their physician colleagues to increase referral and support cardiac rehab?
Well, I think, again, trying to see what the barriers are that maybe individual clinicians may have, whether it's lack of understanding about the evidence behind cardiac rehabilitation or what it actually means. I think education is a big part of that. I think also helping the clinicians to understand the ways to get people into cardiac rehabilitation that may be easier than they think, especially if you have the automatic referral system and the liaison in place, that some of the barriers can be taken away from the clinician side. And one final thing would be that in many centers where it's more of a private center, I'm at the Mayo Clinic where we have more of a central unified group-based program and group-based practice, but where there are private practices that feed into a hospital, sometimes there's competition, and some clinicians may feel like a rehabilitation program is trying to take their patients away from them, or there may be some competition that could be a barrier. And I think in those cases, too, it's very important for the cardiac rehabilitation professionals to make it clear that we are here to help. We are not here to take patients away, but we're here to help improve the quality of care and make sure that they continue with their usual clinicians in follow-up care. So those are a couple of things.
Another one, just real quickly, could be we have a lot of grateful patients, and when they get done with the program and they say, "What can I do? What do you need?" A letter to your doctor saying how much you got out of this program goes a long way to that doctor with the next patient saying, maybe I should prescribe cardiac rehab, because some of it is just habit too. So patient appreciation.
Greg, any final words, and then we're going to wrap up?
I completely agree with the last comment, including the potential of partnering with, so some of the ways you might be persuasive to other clinicians is to have a clinician and a patient partner who's grateful to do a grand rounds type thing to talk about why this matters, and that may be persuasive to some folks to hear the story.
Mm-hmm.
Fantastic. Well, thank you to all of you, to our panelists, for your thoughtful responses in your presentation today. I want to just close out by thanking everybody for their time today and for your thoughtful questions as well. I want everyone to know, on behalf of our TAKEheart training team, that you will receive follow-up information in an email in the next day or so with more information about TAKEheart and where to get more information, including links to the TAKEheart website. We're going to be sending these slides, which again have links to resources we've mentioned and citations underscoring a lot of the evidence, or all the evidence we've discussed. We're also going to send a copy of the cardiac rehabilitation change package that we discussed earlier. And if your question wasn't answered or you'd like follow-up on your answer, we will make sure you know how to get in touch with us moving forward. And many things that were raised today we'll be continuing to discuss on future webinars and opportunities in which we'll be able to be in touch with you. So thank you very much for your participation today, and have a good rest of your day.
do the first 3 slides. Just read those again as though you were with the audience. That should do it.
Hang on 1 second here. Do you need to advance the slides, Jean, or?
Yeah, I can always put the audio under the existing slides, but we might as well advance them while you talk, just in case that's easier.
Okay, so
do it, or you want me to do it?
I can do it. I just need to. Okay, just see if they're gonna. Okay, they're gonna move. Okay. So just the first three. The first 3, right? So it's just
Exactly.
the introduction.
Right.
All right, hang on 1 second. I just need to find that CEU slide. Okay. Tell me when to start.
Go for it.
Go
right ahead.
Okay. Hi, everyone. Welcome to the first TAKEheart training module, and thank you all for joining. Today, we're going to talk about the benefits of increasing cardiac rehabilitation participation. I'm Lisa Leroy, and I lead the TAKEheart training team. The American Board of Quality Assurance and Utilization Review physicians. All right, let's start over, Jean.
That's fine.
Sorry, I forgot.
You don't have to redo the first slide. You can just start from the second.
Okay. The American Board of Quality Assurance and Utilization Review Physicians designates this live activity for a maximum of 1 AMA PRA Category 1 credit. Anybody who is attending the webinar will receive via email tomorrow a form to fill out to obtain credit. We are so pleased today to have 3 national cardiac rehabilitation experts leading today's presentation on the benefits of increasing cardiac rehabilitation. They bring a wealth of experience and knowledge to this topic. Dr. Randy Thomas is the medical director for the Mayo Clinic Cardiac Rehabilitation Program. He is the current chair of the American Heart Association's Council on Clinical Cardiology, and he's published widely on cardiac rehabilitation. Karen Louie is a nurse and exercise physiologist who directed hospital-based cardiac rehabilitation programs for 25 years. She is now at GRQ and serves as a legislative and regulatory analyst for the American Association of Cardiovascular and Pulmonary Rehabilitation, and that involves working closely with the Centers for Medicare and Medicaid and also with Congress. Greg Merritt is the founder of Patient is Partner. He has spent the past 3 years studying, speaking, and writing on the topic of authentic patient partnerships, both in research and practice. He is also a cardiac rehabilitation graduate. Greg is going to start us off with his personal story about the benefits of cardiac rehabilitation and why all of this matters.